Okay, good evening. I'd like to introduce myself, Rob Wagner. I'm your current COMS president. Want to welcome you to tonight's educational webinar. Just a reminder for anyone who has not turned off their camera and microphone to please do so. And hopefully for most of you, this spring is, in full bloom. It's not where I am, but it's brought less snow, more sunshine, renewed sense of vigor after a fun long winter. And we are 3 years from our start of COVID. And now we're starting to see life being more normalized in many ways and maybe changed permanently in other ways. So I'm sure you agree that having the opportunity to connect face to face, like many of us have done, such as the ski and learn that we just had in Lake Tahoe, and also plan to do so at the upcoming ICOMS meeting in Vancouver in June. Will be more wonderful connections that you can make in person rather than on Zoom. Nothing replaces face-to-face communication. And these educational webinars that we have now have provided great auspice to join together to go over to fantastic topics with fantastic speakers. And a reminder to all of you of our previous webinars are available on COMS YouTube site if you're not subscribing to that already. It's easily accessible from the homepage of your COMS website. Before we introduce our speakers, I would like to thank tonight's sponsor who enabled us to join or to host this webinar. Cinca and BTI have supported COMS over the past year in our monthly newsletter and have signed on to present a lunch symposium at the ICOMS meeting in Vancouver. If you have not yet registered for Vancouver, you really should. Not only will there be over 125 Canadians there signed up, but it should be over 1,000 surgeons from around the world in our own backyard in Vancouver. Great opportunity, is so close to home, and if you haven't been to an ICOMS meeting before, it's something worthwhile going to. I want to thank Cinca and BTI for their support, and I would ask to watch a short video presentation from them.
Use of Enduret, PRGF, in oral surgery. The use of Enduret, PRGF, was one of the main advances in implantology. This autologous technology, combined with implantology, has enabled us to improve the survival rates of implants and has provided other advantages in other types of oral surgery: grafts, expansions, recessions, extractions. The patient's autologous proteins provide the regenerative potential necessary to optimize the surgery, to accelerate healing, and regenerate the future areas where the dental implants will be inserted. This is why it is one of the pillars on which our biological approach to oral implantology is based, supported by a large number of scientific publications.
So thanks to Abby Bomick, hopefully I pronounced that correctly, National Sales Manager for Cinca and BTI, for supporting tonight's webinar. And now I'd like to introduce tonight's speakers. So Dr. David Suka, as many of you know, is a graduate of dentistry and oral maxillofacial surgery from the University of Toronto. He's a founder of Fountain View Oral and Facial and Implant Surgery in Mississauga, where he has practiced for the past 38 years. He is an assistant professor at the University of Toronto, Faculty of Dentistry, where he teaches in the graduate oral maxillofacial surgery program, and is co-director of the University of Toronto Fellowship Program in Advanced TMJ or Orthodontic Surgery. In 1995, he co-founded the Mount Sinai Hospital Center of Excellence in TMJ surgery, and still remains there as their senior surgeon. He's attending surgeon at Trillium Health Partners and the Sinai Health System hospitals. He has presented over 150 lectures and demonstrations across North America, Europe, and Australia. He received the Ontario Dental Association Award in 2009 and the Canadian Association of Oral Maxillofacial Surgeons Distinguished Service Award in 2021. Dr. Peter Ta, who will be lecturing as well, is an oral maxillofacial surgeon who practices full-scope oral maxillofacial surgery at Fountain View Oral Surgery. He completed specialty training in oral maxillofacial surgery at the University of Toronto in 2014. During specialty training, he completed a Master's of Science in the field of bone biology with particular focus on bone grafting and regeneration. In addition to private practice, he is an active staff surgeon at Sunnybrook Health Sciences Center and Trillium Health Partners. Once again, we will take questions following the presentation, so please send them through the chat. So Dr. Tony Shahadi at the end will moderate the Q&A session then. Please welcome Dr. Suka and Ta. Thanks so much for attending.
Thank you, Rob, and good evening, everybody. It's an honor for both Peter and I to have the opportunity to speak to you tonight. I just want to say how happy I am to see everybody. I saw all the names popping up as we opened the waiting room, and so many people that I've known for many years but haven't had a chance to see because of our world order issues. And so nice to see you tonight. I just want to reiterate my enthusiasm for the Vancouver meeting coming up in June. Really looking forward to seeing everybody in 3D at that time. Next slide, Pete. So tonight we're going to talk about the use of platelet-derived growth factors in two applications in oral surgery: alveolar ridge reconstruction, and also in managing temporomandibular disorders. Next slide, Pete. And we thank you for the kind introduction, Rob. Next slide. And I just want to, next slide, Pete, I'll just say a word and then over to you. I just wanted to mention that our involvement with the use of platelet-derived growth factors is actually the result of a CAOMS meeting interaction that I had a few years ago when our meeting was in Montreal. And I bumped into Jean Poirier in the hallway. I hope John's here. Hello, John, if you're there. And I bumped into him in a hallway, and he said, "Come on, I'm going to a lecture on platelet-derived growth factors over at another meeting. literally across the street. So I went with Jean and listened to a lecture on the use of platelet-derived growth factors in oral surgery and some of the science behind it. And that's what tweaked my interest in this. I was really impressed with some of the evidence I saw. So it was actually at a CAOMS event that I was first introduced to this, thanks to Jean. And so here we are a few years later talking about it.
Yeah.
On to you, Pete.
Yeah, no, as Dave was saying, this is it was great. Dave brought the product back, and we use this for a lot of our clinical cases. But as a full disclosure for tonight, Dave and I are paid speakers for BTI Underwrit, in particular for the PRGF product. But a lot of the cases we're going to share tonight are really cases that we kind of put together and through using the product had so much success and really developed this relationship with PRGF with BTI because of the success we had. So we're excited to share these cases with you. I want to thank Abby for having us tonight, and again, like Dave said, thanks to the CAOMS for having us share these cases tonight with everybody. I thought it'd be nice just to start the presentation off with a clinical case, and this is a case I think we all face in everyday practice. An aesthetic anterior case. This patient was referred in for reconstructing her 1-2 to 2-2. And I think we can all agree this is an aesthetic case. This patient has a gummy smile. But obviously, a lot of times we get referred these cases, not only because they're aesthetic cases, but because there's a volume problem. And I think as implant surgeons, as oral maxillofacial surgeons, on a day-to-day basis, we're faced with the same dilemma or the same type of referral who ask us to put implants into sites that really are deficient in bone. I always feel like that guy on the right side of the screen here trying to shove implants in where we know it just won't fit. But tonight, Dave and I are excited to share with everyone here the techniques we've developed through using the PRGF product. We found this product to be rather successul, reproducible, and it's allowed us really to change the way that we approach our alveolar grafting to create that bone volume for these reconstructive cases.
So, bone grafting is a core, spinal element for oral and maxillofacial surgeons. And we all have experience in the various ways of building bone up in particular in preparation for implant surgery. And so the use of autogenous bone has been the gold standard in the past, though you'll see there are places where xenografts and allografts with barriers are applicable using guided bone regeneration techniques. Alveolar ridge osteotomies are another tool that we won't be touching on tonight, but they can be a very useful tool for deficient ridges. But tonight we'll be focusing more on the biological approach to bone regeneration. Next slide, Pete. So these are all techniques that we're all familiar with. These are, maybe until recently, were the gold standard in terms of augmenting deficient ridges. Using cortical cancellous block bone grafts harvested from the chin or the ramus, very predictable, something easily done in the office setting. Next slide. And it's autogenous bone, and the healing. Next slide. Is generally predictable. Although I dare say you'll see later that our ability to shape the alveolar ridge is maybe more challenging with these block grafts because we have to carve and sculpt away bone rather than shaping it the way I'll show you later. Next slide. For cases that require larger volumes of bone, we're all comfortable with harvesting iliac crest grafts either from the posterior hip or, next slide, the anterior iliac crest. And that, gold standard, this is a predictable place to harvest variable volumes of cortical cancellous blocks or particulate marrow. Next slide, please. Just slides of how blocks can be pre-carved in the anterior iliac crest for onlay grafting. Next slide. And of course, particulate marrow can be scooped out from the marrow space of the hip. And oral surgeons have been using this technique for decades. This is an example of cortical cancellous block onlay in a severely atrophic maxillary alveolar ridge. Next slide. Which provided predictable healing. Sinus lifts were done at the same time, and implants were ultimately feasible. Next slide. This is a case that I saw over 20 years ago. After orthognathic surgery, the patient wanted to have fixed dental work, so she was treated by me with iliac crest cortical cancellous block onlay grafts. Next slide. So you can see the onlays both in the maxilla and mandible. Sinus lifting was carried out as well. And the four very thin implants that you see were temporary implants that were placed. Next slide. And these were placed to prevent the temporary prosthesis from compressively loading the onlay grafts, which can be a real problem both in terms of maintaining mucosal flap integrity, but also the bone graft itself. And after 5 or 6 months of healing, we were able to place the implants, as you see here. So this was her final restored result with fixed bridges. Next slide. And that's her clinical appearance about 20 years ago. And next slide. But she brought her husband in a couple of months ago to have some extractions done. So I thought, what a great opportunity to take some pictures. So I was able to get 20-year follow-up on this patient, and she has maintained. She's done a great job of maintaining her implant-supported prostheses with maintenance of good bone levels. We all know that that's not always the case with autogenous cortical cancellous blocks, but this is an example of a case that has had a really good run with the treatment. Next slide. And again, speaking to other types of bone grafting techniques, there are simpler techniques for smaller defects. I'm a fan of the subperiosteal tunneling technique that was popularized by Michael Block years ago. Using really minimally invasive surgery, a subperiosteal tunnel can be created and the bone grafting material can be injected into it. This works well for widening the crestal aspect of a deficient ridge, not so much for gaining vertical height. Next slide. And these are just examples of how those grafts have the potential to heal. Next slide.
So I think just through the clinical cases, we thought we'd show some autogenous grafting and show that when we take a step back from what we kind of do on a day-to-day basis, it's really amazing, the body's capacity to heal. We're able to transplant bone or move bone or create bone really out of nothing. And I think sometimes we take this for granted, but when we take a step back, it's truly amazing what we're able to do given the right correct parameters. And we think of tissue healing in general. We know tissue goes through the 4 phases: the hemostatic, inflammatory, proliferative, and remodeling phase. Tonight, we'll be speaking in particular of regenerative medicine and growth factor-based healing. And this is utilizing growth factors to stimulate blood supply, improve cell numbers, as well as getting the right cells to the right place really at the right time. And this is controlled through growth factors. As Dave alluded to there, the gold standard really is considered autogenous bone grafting because we think of the 3 pillars of bone grafting: the osteogenesis, or having the bone forming cells there; osteoconduction, having the right scaffold. But just as important, I think, are the osteoinductive factors, the growth factors, which function not only to bring cells there, but to increase cell numbers and to increase and to change their final lineage as well. In general, when we think about primordial cells or embryos and stem cells, the function of the growth factors, as I mentioned, through chemotaxis, recruits the cells to the local site that we want them to act. They then increase mitoses to increase their cell numbers and the rate at which they replicate. But they also, through growth factors, can define definitive cell lineage for these stem cells. And so through PDGF, IGF, VEGF, BMP, NGF, these multipotent or pluripotent cells become their final cell lineages, which really is what we want, the osteoblasts and bone reconstruction in particular. My interest in regenerative medicine and in bone-based healing really started off through my master's project as part of my oral surgery training. The 4-year study really utilized BMP, or bone morphogenetic proteins, for stimulation of bone growth. My focus in particular was developing a scaffold that would really deliver the correct amount of BMP at the right time. And really what we did in these studies was using the mouse model in the hind legs of mice close to the femur, but completely in a muscle pouch devoid of any osteoblasts. We put different types of BMP bioimplants. We inserted the bioimplants, we put clips on there and let the mice heal. And the intention was to let the mice run around for about 21 days. But what we saw was that the BMP and the growth factor-based bone regeneration was so effective that we actually had to sacrifice the mice at 14 days. What you see here is a 3D reconstruction, and on the left side, you'll see the axial view of the femur of the mouse. And so that is really inside the ossicle you see on the left side is a newly formed ossicle, which used the BMP to stimulate mesenchymal cells inside the muscle to become osteoblasts and form bone. And so this is really really quite neat, and really set off a light saying, holy smokes, this is pretty cool. And it's great that it can be used in the mouse model, but is there a way that we can apply this effectively in our practice every day as oral surgeons? And through special approval, we were fortunately able to have some clinical cases that were able to use the BMP bioimplant as an alternative to autogenous grafts. This CT here is a 20-something-year-old male that had a recurrent ameloblastoma of the left mandible, and he required a segmental resection. With special approval, we were able to use the BMP bioimplant as an alternative to any posterior iliac crest bone grafting. And this is the resection that we have here, a large segmental defect. And rather than using a block bone from the iliac crest, we used a combination of BMP and dynagraft putty, and kind of molded off a piece of the mandible to reshape the mandible that was resected. After about 6 months of healing, it was really quite amazing what happened in the reconstruction. The left mandible completely integrated. We formed new bone. It's always neat how you see form fitting function, and that a new coronoid process was developed as well. But what was really neat was that the bone, on going back and reconstructing these sites with implants, was vital bone. So core biopsies were performed when the implants were going in, and they showed healthy bone with live osteocytes and good vascularity, and the implants were able to integrate. This is a post-operative photo showing you can kind of see in the left photo there the reconstructed molars on the left side there. So this was really great. It really set off that light bulb. It got us interested in regenerative medicine. But I think as oral surgeons, we all know that there are challenges with BMP. Sometimes it can be cost prohibitive. There are times that we can use it, and there's some off-label uses you can have, but there are contraindicated times that you can use it for patients like who may have sarcomas. So when Dave brought this product over and brought it back from the CAOMS meeting, it was really intriguing, using growth factors that were readily accessible by drawing the patient's blood, centrifuging it, and that's really all we needed was a centrifuge and the test tube vials that came back to have this readily accessible and readily available whenever we wanted to use it. This video kind of goes through the whole process of how the PRGF is isolated. In the protocol, we usually bring patients to our clinic about 30 to 40 minutes early. We draw their blood. The blood is then spun, and it's through a patented centrifugation process that BTI has that really concentrates the plasma into different layers. and the different layers correspond to different amounts of concentration of the platelets, which ultimately contain the growth factors. The F2, which we'll see us really refer to shortly, is the concentrate. It's about a 2.5 time concentrate of platelets in the plasma. And these are undegranulated platelets. And so until activation, the growth factors are still held inside the platelets, and upon activation can start to be disseminated.
So the star of the show here are platelets, and we often think of the appearance of a platelet in a histological slide. They're just kind of a bland-looking yellow-shaped oval, but they really are a very interesting cell. They are anucleated cytoplasmic fragments of megakaryocytes, and they contain a pretty robust endoplasmic reticulum, which is capable of producing multiple different proteins or cytokines that we refer to as growth factors. Next slide. So these growth factors are stored in alpha granules, which upon activation of the platelet can be released into the environment. And these growth factors then bind to the extracellular membrane of the target cells, and they trigger a phosphorylation reaction within the cytoplasm of, say, a stem cell, which ultimately causes gene manufacturing, and the type of growth factor determines what the gene will be in the ultimate cell type that will be created, be it a chondrocyte or a fibroblast or an endothelial cell for blood vessel angiogenesis and neovascularization. And these on the right are as a list of the growth factors that are released from degranulated platelets. And we'll be talking and referring to these again as we move through this presentation. But the other point is, with the technique that we use, the growth factors are concentrated into supraphysiologic concentrations. And the F2 that Peter talks more about, it has actually 2.4 times the normal concentration. And that can be particularly theoretically, realistically helpful when we're delivering this high level of growth factors to tissues that typically have poor vascularization anyways. Like cartilage, like bone grafts, like tendon and ligaments, which where this material is also used for regenerative medicine purposes. Next slide, Pete. And so we are on 46. So this allows us to create a solution, a liquid solution of concentrated platelet-rich growth factors. With the particular system that we're using, we can bake this in an oven at 37 degrees for about 8 or 9 minutes, and that can turn it into a clot. And we can mix allogeneic bone grafting material or xenogeneic bone grafting material with that to form what we affectionately refer to as sticky bone. It's like a bone grafting putty. Next slide, Pete.
So essentially, the growth factors that are concentrated, first off, Dave alluded to that 2.4 time concentration of platelets, and really at the cellular level, what does this really do? We alluded to chemotaxis, bringing cells there, and mitosis. So on the right side, you'll see through fluorescence microscopy, relative to the control, tissues that were exposed to the PRGF were much more numerous in cells because they were attracted through the osteoinductive factors. as well as they were much more numerous because they produced much more mitoses as well. And so, as Dave mentioned, they're really the star of the show is the F2. When the blood is concentrated, we have plasma concentrates of platelets at 2.4 or 2 to 2.5 times. And through this, we can create different products. We can leave it as a solution. We can bake it to make it a membrane, or we can mix it with autogenous or zetogenic bone or allogeneic bone to pump up the growth factors in it. And in regenerative medicine and in oral surgery, the PRGF has been documented or reported to be used in bone reconstruction, which we'll chat about a lot tonight. It seems to be a really hot topic in the use for TMDs. And soft tissue augmentation is something that's also being used with the PRGF. But I think when Dave brought the product to us, as any cautious oral surgeon would do, we wanted to take this in phases. So first, great product. I think we've seen a lot of great products at trade shows and different membranes, amniotic membranes. Everything seems to be fantastic when we see it. But the question is, does it really work? The literature that we had out there for the PRGF, a lot of it's been published by Nitwa, who was an oral maxillofacial surgeon in Spain, and his use of the product in split mouth studies comparing socket preservation procedures with or without the use of a PRGF showed statistically significantly greater healing when the sites were treated with a PRGF clot. So in a similar fashion, when we first brought this product back, we used it first to get a feel for the material and really too to see if this product really made a difference in the healing. And so in cases where we were planning on doing fixed implant bridges, crowns and bridges, where we really wanted to maintain bone volume, this seemed like a good opportunity to really expose ourselves and become familiar with the product. And so this patient here had a maxillary edentulation, planned for full implant-supported crowns and bridges in the maxilla. And for this patient, I grafted using a PRGF sticky bone. So that's using the F2 liquid mixed in with the allogeneic bone. And we baked it to make the sticky bone that you'll see on the upper left here. So I onlayed that into the sockets, used them as socket preservation procedures, and kind of onlayed it onto the alveolar bone as well. The F1 is really considered fibrin. I think F1 or FI as in fibrin. This has about a 1 to 1.5 time concentration of platelets, so it is slightly supraphysiological. But the purpose of this concentration is to facilitate soft tissue healing. This is the graft closed, or the site closed. And the patient came back, as we'd expect, a week after surgery, looking pretty good. It's not uncommon to have a similar type of result without a PRGF graft. But what was really neat for this patient, they came back relatively pain-free, and it did seem like there was a difference in the amount of surgery he had and what we would expect post-operatively. And so using the case more and more on simple procedures, it only made sense to consider using this material in another predictable procedure that we do as oral surgeons, or sinus lifting or maxillary sinus augmentation. And as we all know, it's a predictable procedure. I think you can use autogenous bone, you can use allogeneic bone, you can use xenogenic bone, and they all seem to work. But as we all know, not all sinuses are created equal either. And there are some cases that are more challenging to lift. This patient in particular had a pretty prominent maxillary antral septum and the left pneumatized sinus. And this is, the patient also has a little bit of sinusitis, the septum transversed from the lateral to the medial wall of the sinus. And the consideration is that when we lift the sinus, it gets a little frustrating when we start getting perforations, in particular around the septum. And having used the product a little bit, what I found was really neat with this, and this is why I routinely use it, is that the fibrin for moderate sized perforations functions extremely well, like a tire patch. So we've tried rolling over the Schneiderian membrane to close defects. We've tried putting in not a resorbable membrane, but what I find works best in these cases is the F1. It seems to just have good resilience and patches up those holes like you would patch up a tire. In this case here, we were lucky we were able to lift off the maxillary sinus. There was no perforation. But rather than putting just the xenogenopum or biowas in there, I mix the biowas in with the F2, and this makes a sticky bone. This is almost like a second layer of comfort I may have as well if there are perforations, because the sticky bone really it's sticky. It consolidates. It's almost like it's like a gelatinous type of material that has some volume to it, but we don't have loose particles that may migrate up into the sinus. And so after inserting the graft, we close, and then we let it heal. And predictably, as we would expect, this did heal. I do find the benefit is that we use much less biowas as well, because the F2 does take up volume. And the question is, does this F2 really add to the quality of the bone, or does it detract, or do we get more voids inside that bone? And on this post-operative CT, what we do see is that the bone integrates. It's dense, it's type 1 or type 2, and we see this repeatedly. So I routinely use the PRGF for all my sinus lifting procedures, because it adds a layer of comfort for me. I know I can deal with small perforations of the schneiderian membrane predictably, and the healing seems to be quite predictable as well. So then we get more comfortable, and we take it to the next level. We start thinking, can we use this material predictably in ridge augmentation? This clinical case is a patient that had a congenitally absent lateral incisor. It's not a huge volume defect, and I think prior to bringing this material to our clinic, I would have routinely gone to a ramus graft. It's a predictable procedure, and would have used it as an onlay. But we know that having a ramus graft is not completely benign. It does increase the patient's exposure to pain, being a second surgical site. We are working around the inferior alveolar nerve, so there is always a risk of numbness. And probably not in this case, but perhaps when we're trying to stretch the limits of what volume defect we can reconstruct with a ramus graft, we may put the patient at risk of a pathological fracture, as well as we get a little bit overzealous. So our shifting has really gone away from autogenous bone grafting and has really gone towards this growth factor-based regeneration. And really our workhorse is the F2 or an F1 or the sticky bone with a pre-bent titanium mesh. So the protocol is the same. We pre-bend a titanium mesh for these cases. We isolate the F2 and we bake it with allogeneic bone. And then as part of the isolation procedure and getting the F2, we also have an F1 membrane that we also bake to create that clot. This is an intraoperative photo of the patient on the left side here. I know that in grafting, it's not necessarily necessary to, or it may not be required to perforate the cortex, but intuitively it makes sense. We make some perforation holes to improve the ability for the blood vessels to grow into the newly formed bone that we want to create. This is the pre-bent titanium mesh that we have. And at the time of insertion, I fixate the titanium mesh to the alveolar crest with a single fixation screw. Once it's fixated, I oftentimes just elevate that mesh. I take my sticky bone, adapt it to the exposed alveolus. In this case, I place the F1 on top of the sticky bone, and then I replace the titanium mesh down and close around it primarily. This was the patient 6 months after healing. And this is the part that we always love. Dave and I and the guys at the office, we call this the unveiling procedure. We lift the flap and we're always amazed at how well this technique works. You can see the single fixation screw here at the alveolar crest. And this video shows one of the challenges at the implant placement phase, in that the titanium mesh can be quite tenacious to remove, almost as if for those of us who've worked with those MedPOR implants in the past, the soft tissue really grows in and around the titanium mesh. So removing it actually is quite a bit of work. I think Dave has a technique where he kind of puts a clamp on there and rolls it up like one of those fruit roll-ups we might have been familiar with as we were kids. But it really does incorporate into the soft tissues. And I do find there's almost like a fibrin layer surrounding the newly formed bone that exists as well. But what's always nice to see is once we do get that mesh off, to see healthy, vascularized bone and really the contours that we wanted it to be in the first place, having a pre-bent mesh. It really never gets old. We bring each other into our operatories all the time and say, look at what we created here today. And so this clinical photo here shows that the grafted bone, the implant's been placed. And you can see we have more than enough bone to work with. And this is what we see repeatedly. So on these small grafting cases, it seemed to work extremely well. And the protocol, again, was pre-bending a titanium mesh, using the sticky bone with an F2 clot mixed in with an allogeneic bone, and using the F1 membrane that we would isolate to facilitate soft tissue healing. And so as we started working with small alveolar defects, it kind of got to the point where we're saying, wow, this works so well. Like, how far can we push the limits? What can we really do? How much can we really do? And what can we really reconstruct with this technique? And this is where things started becoming really exciting. And it brings us back to full circle of how we would treat this patient here, where we had shown the alveolar defect with a pre-bent titanium mesh utilizing PRGF and an F2 sticky bone. We started producing results like this: tons of bone, the amount of bone that we may not have been able to achieve with autogenous block grafting. And this allowed us to place implants to reconstruct dysplasia predictably with guided surgery. And I think Dave now is going to show a couple more cases of these larger reconstructions that we've done.
I think now let's go to 83, Pete. So we just, as we became increasingly more comfortable with the technique, we began thinking about applying it to increasingly more severe cases. And I just sorry, are you able to go back to one slide there, Pete? So this is a case, the patient had failing bridge abutments and wanted to convert to anterior and posterior implants. So next slide. And this is the CT showing, a fairly common deformity in severely atrophied patients with horizontal atrophy. Vertical height's not bad, but there's severe horizontal atrophy and apical concavities. Next slide. Just a close-up of the cross-section of the anterior and a close-up of the 3D CT. And just hold it there. So what we've been doing is we've been using our cone beam CT scan that we acquire in the office, and we're printing 3D models from that, like the ones you see here. And these models actually demonstrate the severity of the apical concavities and the horizontal atrophy quite nicely. Next slide. Just another example of a 3D model that we've printed from our own cone beam CT scan. Next slide. And using these 3D models, we can then pre-bend the titanium crib that we intend to use at surgery. And I like doing this. You can sit at your desk, have a cup of coffee, take your time, bending this thing so that when you actually come, of course you sterilize it, but then when you come to the OR, it's all done. And you just onlay your bone to the defect and drop this on top of it. Bending the tie mesh is, for those of you who may remember the old DAT tests, remember you had to unfold up a flat structure and create the 3D structure that it would turn into. Well, this is sort of the reverse. You have to picture in your mind how you want your crib to look, and then trim and cut the mesh and then bend it to achieve the result that you want. Next slide. And I sort of developed my own preference for doing this, where I aim for a 7 millimeter thickness at the alveolar crest, and then I have 1 or 2 millimeters to the lingual or palatal, And then the labial or buccal part, I try to create at least 10 to 12 millimeters of vertical height of bone. And if you look at the crib on the mesial and the distal aspect of the labial flange of the crib, you'll see the little wings that are bent in. And those wings prop the labial flange out, creating the thickness. Next slide. So this is that case at surgery. So the right side has already had the bone graft placed and an F2. In this case, I soaked a collagen membrane in the F1. So you can see the difference between the new bone thickness and the left side, which hasn't been treated yet. And then on the right image, in this case, I used two separate titanium cribs. So then the crib is laid on top of the bone and tacked into place with one or two. These are 1.5 millimeter screws. And next slide. And so then the same treatment on the left side with the bone graft and the membrane placed. The next slide. And once the mesh is placed, we also place the F1 membrane on top of all of this. And that helps to sort of protect the mucoperiosteal flap that's going to close over top of this. The right side shows immediate closure. And here it's useful to talk about the importance of tension-free closure. It's a basic surgical principle. We're all familiar with that. But it's really important here to minimize the potential for dehiscence of the tie mesh. So a really good release of the periosteum at the base of the flap is important. The other thing that's important, I believe, is to have a widely based flap. I usually go at least one tooth beyond where I'm grafting either way, so that there's a good vascular supply to the flap. My own preference is to use sutures that last a long time, like Biosyn or Vicryl, that last 4 to 6 weeks. Next slide. So that was an example of one case. This is another. This was actually one of the first cases that I did. So this patient came to me. She had a history of ameloblastoma, which was treated elsewhere with a marginal resection and an iliac crest block bone graft. And although the vertical height appears reasonable, next slide, there was quite a bit of horizontal bone loss. And this I think we see more often than not with autogenous cortical cancellous block grafts. Next slide. And again, the cone beam CT scan demonstrates the actual horizontal atrophy that occurred, really leaving inadequate thickness for the ability to place implants. Next slide. And there's a clinical view of the exposed area, and you can see how much of the screws have become exposed. That just shows how much, presumably those screw heads were flushed with the bone graft, and now they're quite prominent. So you can see to what extent bone has actually resorbed in this case. Next slide. So this is the tie mesh graft being placed. Over the tie mesh crib being placed over the bone graft with sticky bone. And again, the same principle of, the 7 millimeter width at the crest of the alveolus with a little lingual down bend on the crib. And the other thing I just like to point out is, again, you can actually round out the buccal labial edge of the graft by making a rounded bend, as opposed to having a squared off block that you have to maybe flatten by grinding it to round it out. Next slide. And that's just the membrane going on over the graft. Next slide. So I think this is at re-exposure. Is that the video, Pete?
Well, I think this is just
That's just, okay, that's just the crib in place. And that's the crib in place. And so this is 6 months later. And just raising, like Pete says, the reveal and showing how the bone is healed underneath the crib. You know, it's healthy bleeding bone. There's good thickness. And again, I think the other thing I like about this technique is by managing the way you bend your crib, you can shape the alveolus. In 3 dimensions, you can curve it. Next slide. And that allowed us to then place implants, which went on to be successfully restored. So as I say, this was one of the first cases I did using this technique. It's been a few years, and she continues to have healthy peri-implant bone. Next slide. Now, this is a patient that I think was another challenging case, actually, and showed me what the potential for this technique really is. So you notice that this patient had a Lefort 1. Well, in fact, I did orthognathic surgery for her about 20 years ago. And a couple of years ago, she went to her dentist. She had some endodontic problems with her anterior maxillary teeth. So the dentist did an endo on a couple of the incisors. And the patient recalls while she was having the treatment done, she could smell something burning. And ultimately, she began to dehiss the alveolar bone around the roots of these teeth. And eventually, she came to me, and eventually we had to remove some of the teeth and the bone that had become necrotic from overheating during the endo treatment. And I think that's apparent in the next slide. So you can see how much bone she lost. And this is a complex defect. It's a 3-dimensional defect, horizontal thickness and vertical height, and severe loss. Now, the slide on the right shows a red line connecting the bone on the lateral, on the adjacent teeth root surfaces. And this, I just wanted to underscore a general principle in alveolar bone grafting. The most that you can ever achieve in vertical reconstruction is determined by the height of the bone on the roots of the adjacent teeth. And so, just as an aside, sometimes if the roots of the adjacent teeth have little bone, or if the bone loss is severe on the root surfaces, it's sometimes, I think, strategic to remove that tooth or teeth so that you end up with bone higher up on the roots of what will be the teeth adjacent to the defect. Next slide. And this just shows the degree of the horizontal bone loss that she had as well. And next slide. So we used this technique. We used a custom crib. I set the height regeneration to the level of the bone on the roots of the adjacent teeth. And we took it up as close to the piriform fossa as possible. On the right slide, you can see in this particular case that you can still make out what was the native bone, and you can see the degree of new bone that's been added both horizontally and vertically. Next slide. And that's just, again, the crib in place. And we were able to remove the crib, and it allowed us to place, the implants for her. Next slide. And she went on to be restored nicely. It's been, I think, about 3 years now that she's wearing this bridge. The slides on the left, I just want to show another principle that we apply for these cases. Because we advance the labial flap to get primary closure over the crib, sometimes the vestibule is lost, and sometimes we end up not having a keratinized tissue band on the labial aspect of the implants. So these patients may benefit from a secondary vestibuloplasty, which is what I've done here. And certainly you can use autogenous palatal gingiva, or you can use autogenous palatal connective tissue. But again, in an effort to minimize donor site morbidity, I've been using mucograft, which is a xenogenic collagen, thick collagen membrane type material. And I've used that a number of times for these vestibuloplasties with good results. And next slide. So, we keep seeing cases that are more and more challenging and more complex, and we wonder if we can apply this technique. So here's a patient that wanted to convert from her RPD to implant retained bridge work. And the slide on the left shows the severe nature of her atrophy, really, classic knife edge ridge deformity. Next slide. And so she was treated using this technique. And I guess the point I want to make with the upper left slide, again, you can shape the grafting to create the curvature in 3 dimensions that you want for the alveolar ridge. And in this case, I did that by using individual cribs to round the corner. Although you can also use a bigger crib and just cut little wedges on the palatal aspect and then bend it to create a curved surface. But so this is an alveolar ridge that is curved both from palatal to buccal with a rounded edge, but also it follows the natural curve of the maxilla. Next slide. And there she is at the uncovering and before and after removal of the cribs with, again, healthy bleeding, nicely healed bone grafts. Next slide. And this allowed placement of the implants. Again, this was a guided surgery. And after healing of the implants, this is her fixed restoration. Next slide. I might mention that we routinely include sinus grafts, with these bigger maxillary reconstructions. So here's another challenging case: a patient with severe periodontal disease. The periodontal disease has caused destruction of the anterior alveolar ridge, bone around the residual teeth, and then also, severe pneumatization by the posterior alveolar ridge by her sinuses. Next slide. And just 3D pictures of the severity of the bone loss in her maxilla and around the few teeth that were still there. Next slide. And again, severe sinus pneumatization and horizontal bone loss, knife edge ridge deformity. Next slide. So again, three-dimensional shaping of the cribs to give a rounded natural ridge form, simultaneous sinus lifts. Next slide. Just a Panorex. In this particular case, I did remove the tie mesh as a separate procedure. She had a dehiscence, but as usually the case, they may dehisce the tie mesh, but the bone is still there. So after allowing some time for the mucosa to mucosalize, I guess, we went back as another procedure to place the implants. Next slide. And again, this is an example of a guided case that we did. The splint was mucosal borne, And I don't do fully guided surgery. I just drill my initial pilot holes with the guide and then freehand the osteotomies to the size that I want. Next slide. There she is with her implants in place. You can see the mucoperiosteal flaps demonstrate the thickness and the nice architecture of the newly created alveolar ridges. Next slide. She elected to have clip-in removable overdentures, which were ultimately delivered. Next slide. Just another example of horizontal and vertical deformity. Next slide. Look at the bone levels on the adjacent teeth roots. There's the crib in place and on two separate sites. Next slide. The implants in place. And this is just another example of where I did a secondary vestibuloplasty to deepen the vestibule near the site with the two implants. Next slide. It's just the radiograph. Next slide. And so, this has become our workhorse for managing these severely atrophic cases with large spans. So I'm showing you this because it's not a one-off. It's something that we are doing pretty regularly with these types of cases. Next slide. Again, the mesh in place. Next slide. I think you're getting the idea now. And again, the 3D curvature that can be bent into the cribs. So notice that the anterior cribs go right up to the piriform fossa. Next slide. Bone at stage 2 or at implant placement. Next slide. And the implants in place using a guided surgery. Next slide. And implants in place. Next slide. She went on to obviously a fixed bridge. Over to you, Pete.
Thanks, Dave. So just one last case here. I know Dave showed some awesome cases, and I couldn't let Dave have all the limelight. They were pretty awesome clinical cases. The last case we'll show here, this was a patient that I was asked to see from a periodontist. And similar type of idea. She was deficient in bone, had a failing anterior dentition, had lost her fixed bridge. And obviously the patient had the deficiency in the bone quite severely in width. The height was pretty good. But what was unique about this patient was she was missing 5 teeth from the 1-2 over to the 2-2. But she was an avid golfer and suffered from rheumatoid arthritis. So the first provision she gave me was that there was no way I was going to do any autogenous bone grafting from her hip because she would rather go edentulous than not play golf for a season. And the second thing for her is she wanted individual implant crowns because she thought her bridge had failed because of her lack of dexterity in being able to get underneath that bridge to floss it. And so I think this is one of the challenges that Dave spoke about. Autogenous block grafting is great, but sometimes it's really hard to shape and really hard to put those block grafts if you don't have adequate volume to get the contours that you really like. And that's what makes this technique really nice is that we pre-printed her maxilla. Using the crib, we create adequate thickness. We create the bone into positions where we want to put the implants. And again, the CTs before the surgery never ceased to surprise us. You can see the native bone and the newly grafted bone and the newly formed thickness of the bone that we've achieved from the titanium mesh pre-bent F2 graft. I've brought the mesh right up to the piriform rim. And when we do the uncovering, remove the titanium mesh, And this is, again, what we see predictably. So a nice, thick, uniform ridge that is adequate in volume to place implants into. And this allowed me to, through guided surgery, place 5 implants into the desired positions to maintain implant spacing. I had the bone thick enough where I wanted to put the implants because of the prevent in the continuous architecture of the bone that's developed in the alveolar ridge. And in this case, I chose to stage the implants because of a concept Dave alluded to, and that when we do these big PRGF grafts and we really pull all that labial mucosa palatally, oftentimes the areas where the implants are may be devoid of some attached mucosa. And so after placing the implants and during the consolidation phase, I told her that we were going to do a connective tissue graft at the stage 2 procedure. So at stage 2, I did put longer healing abutments onto the implants, but when I exposed it using some alloderm, I split the mucosa and the attached mucosa and really tried to get 2 or 3 millimeters of attached mucosa on the labial aspects and apically repositioned it. And it just packed the alloderm surrounding the healing abutments there. This was 3 weeks on the left side. And at 6 weeks post-op, you can see the amount of thick attached mucosa on the labial aspects of the implants, which is really important for a patient like this who suffers from rheumatoid arthritis and may not be able to maintain the peri-implant health. She went on to have her implants restored. She's quite happy. She's actually had a couple other teeth fail, and this for her has been fantastic. It's been life-changing because she was able to get single implant supported crowns where she felt that she was able to maintain the health and the hygiene around. Over to you, Dave.
Okay. Nice case, Peter. The next slide. We've used this technique to rescue some implants that are ailing. In implants like this, where there's been peri-implantitis and bone loss, we've used sticky bone after debriding the exposed metal surfaces to regraft around the implants. Next slide. And I think so there the F1 membrane is placed over top of the graft. Next slide. And even though there's some exposure of the membrane, that's okay. The surrounding gingival cells will migrate and mucosalize that. Next slide. And this is I think this was at 4 months of healing. So we were able to salvage these implants and also improve the health of the surrounding peri-implant soft tissues.
So kind of, as Dave's kind of shown there, I had a couple of cases that were referred for suffering peri-implant cases as well, and this is one of them. And peri-implant diseases is just so tough to treat. But after actually when we were making this lecture, I saw Dave's slides. It's like, well, maybe I'll try this PRGF graft for a case like this. You can see the volume defect on the labial aspect of this tooth. There was thread loss down to the apical third from the preoperative cone beam CT. But on the left side is the preoperative radiograph, the postoperative radiograph on the right side. I don't know if the bone is integrating to the implant surface after debridement. My inclination is no. But I do think we're creating a nice, thick, healthy vital bone on the labial aspect where the mucosa is able to attach to, and we'll closely monitor this patient and see how she does and how this implant does with time. But with any technique, I think we always run into our problems. And Dave mentioned in some of his earlier cases, he had staged the removal of the titanium mesh. I think we've been very fortunate. We've done, it's almost on a weekly basis, it feels that we're doing these PRGF big implant reconstruction cases. And they work, the bone integrates. But sometimes, depending on the size of the defect and how much we stretch the alveolar mucosa, as well as whether working with a thick or thin gingival biotype, sometimes the titanium mesh may dehisce. And in these cases, it's okay. As you can see, the mesh looks quite healthy. We maintain I tell these patients ahead of time that the mesh may show through. But if they're not infected, we're going to maintain it until the bone heals. And we've been fortunate enough that most of these cases have really progressed well. And so in these cases, what we'll do is we'll remove the titanium mesh as a separate procedure. This is a 1 week post-operative photo of that patient coming back after having had their titanium mesh removed. You might have seen from the video, there was almost like a membrane or almost like a periosteum over top of that vital bone. So the mucosa is very, very quick to mucosalize once we do remove that titanium mesh. And this is just in the second case, again, of a dehiscence in the anterior maxilla, just too large to really elevate the flap and make me comfortable to place implants simultaneously. So we tell the patients that we'll stage the procedure. We go in there, remove the titanium mesh. This photo here shows the elevated flap in the vital bone underneath that mesh there. And on 1 week after having the mesh removed, the site essentially has mucosalized. And I do typically wait about 6 to 8 weeks for that mucosa to mature before going back and re-entering the site to place the implants. I think I'm not sure if Dave's webcam's. Oh, there you are, Dave.
Okay, and that's I think that's your slide there, Pete, where you show the area after it's mucosalized. I'll just take a few minutes more now to talk about another application of this technology to oral surgery, and that's in treating TMD patients. And I will say that I was initially motivated to start doing this when COVID came along and we had our OR time. Well, for a long time, we had no OR time. And in the meantime, all of my patients, all of our patients that were waiting for surgery just sat cooling their jets. And the patients who were scheduled to have TMJ surgery, we had no idea how long they would have to wait. But then there was the added issue of them being in pain while they're waiting. So I started trying to do more things in the office to manage their pain, either to get them to surgery or maybe even to avoid surgery. Next slide. We still don't really know what our waiting list is. We're back doing surgery, obviously, but it's kind of hard to calculate still at this point. Are you able to advance the slide, Pete?
I think it's advanced to. What do you see on your side there, Dave?
Here we go. So that has that led to me applying these techniques that can be done in an office setting: intra-articular injections, and there's 3 different materials that we can use for that. I'm going to talk about, and also arthrocentesis, which provides the ability to lavage the joint, to wash out the pain-inducing degeneration-inducing cytokines, but also to provide hydraulic distension of the capsule, stretching fibrosis, and potentially even releasing some adhesions. Next slide. Corticosteroids are sort of the time-honored injectable. They, of course, work as lipooxygenase inhibitors and work as anti-inflammatories. But it's becoming apparent to us in the TMJ surgery world that there's a downside to multiple cortisone injections, and 1 or 2 injections maybe, but after that, there can actually be degenerative changes in the affected joint. So, next slide. Sodium hyaluronate has been around for years. It's Synvisc is the trade name of the product. It's a synthetic hyaluronic acid. or synovial fluid is actually made from rooster combs, and nothing goes to waste. But it enhances the viscosupplementation and viscolubrication of the joint. It improves the way the joint surfaces function against each other, though it doesn't actually seem to promote repair. Next slide. And more recently, then, platelet-rich growth factors are being used as a TMJ injectable, and they have all kinds of orthobiological effects. They have anti-inflammatory effects. They scavenge free radicals. They have an analgesic effect by bonding to cannabinoid receptors. They can be chondrogenic. They can enhance bone repair and remodeling. They're angiogenic, and they can provide a scaffold for stem cell migration. They increase the high hyaluronic acid production from native synoviocytes, and it's been shown that they can actually heal osteoarthritic defects. And this has been demonstrated in a number of papers. And I've actually seen, I'll show you the case actually in just a moment. Next slide. So this is just an example of an osteoarthritic joint. This is a Wilks 5 joint with severe fibrillation of the fibrocartilage and a large perforation. That's the degenerated condylar head, protruding through the perforation. This is an osteoarthritic Wilks 5 TMJ. Next slide. Just advance the slide if you can, Pete. So this technique, the injection is done using the liquid version of the platelet-rich growth factors. And just prior to injection, the liquid is activated. And that's another nice feature, I guess, about this particular technology is you can activate, you can time the activation, you can time the degranulation of the platelets to when you want it to happen, rather than trying to, some techniques, the platelets begin degranulating as soon as they're spun. But this way, just by when you're ready to do the injection, you can activate it, the liquid, and then inject it immediately. Next slide, Pete. For some reason, I think our bandwidth has gotten a little smaller as we're talking tonight.
I'm not sure if that's advanced the slide. Did that slide?
Thank you. So that's great, Pete. So there's been quite a bit published on the use of platelet-rich growth factors in TMJ articular pain. These are a number of studies that have been published over the years. Most of them are observational, studies with small numbers of patients, but there are a few meta-analyses as well. And don't worry about, for those of you that are interested in the references, we're going to give you a reference list at the end that for those who are interested, they can track these references down. Next slide, Pete. But this is one meta-analysis that I did want to just review with you. This was done by Joe McCain and his team at Harvard, and just published in 2021. They did a systematic meta-analysis of comparing the different intra-articular drugs used for treating TMDs. Next slide. They looked at over 2,400 articles, but ended up having only 9 studies that met their inclusion criteria. But this still had 443 patients. The minimum follow-up was 6 months. Next slide. And the Reader's Digest version of their conclusions, there was significant pain reduction in the patients with all of the techniques, and also improvement in the range of motion. But they found that arthrocentesis with intra-articular injection was better than either modality performed by itself. They also found that although all the injectables are helpful, platelet-rich growth factors was superior to HA, which were both superior to steroid. Next slide. And so this is something we do in our office. So I do it in one of our ORs under intubated general anesthesia, but people are doing them with IV sedation and local as well. Next slide. So if you can just run the video, Pete. So there's this technique involves an inflow needle and an outflow needle. We hook up a line that we can gradually inject the fluid. Okay, next slide, Pete. It's a video as well, Pete. And this is McCain's entry point for arthroscopic surgery. We use the same points. The second outflow needle is 5 millimeters ahead and 5 millimeters inferior. And we try to run about 100 cc's of fluid through it. So there have been studies that shown that you need a minimum of 100 cc's of fluid to completely dilute the pain-inducing cytokines. Next slide, Pete. This is just an example of one patient I did. That's on the left. It says pre-operative opening. He had severe degenerative joint disease. He had pain. He had limited mouth opening. The slide on the right is in the recovery room after he's had his arthrocentesis and PRGF injection. And he came back a week later. He was pain-free. And I followed this guy for a couple of years, and he's continued to have good function and good comfort. Next slide. So in summary, PRGF with or without arthrocentesis, it's safe with limited adverse side effects. PRGF seems to, at least with the current literature, seems to be the best of the injectables. It can, the other thing is it can be repeated. So even if somebody gets relief for a while and then their pain comes back, you can repeat the treatment for them. And it actually seems to promote healing in degenerated joints. More RCTs with standardized methodologies and more meta-analyses are needed to further prove the point. Next slide. My friend Jonathan Abili in Montreal shared his experience using platelet-rich fibrin injections, and he published this experience in Cranio. Next slide. And they had 37 patients. They had a different injection protocol. They did 3 injections a week apart, and they followed their patients for a year. And the patients were basically pain-free with improved function after a year. Next slide. And Jonathan was kind enough to share these x-rays of one of his patients. On the left, the 2 x-rays show classic signs of severe degenerative joint disease with articular erosion, subchondral cysts, flattening. And on the right, a year later, there's been some healing. The subchondral cyst is healed, and there appears to be an actual new layer of cortical bone forming on the articular surface of the condyle. Next slide. And this is just a graph showing how the range of motion improved over 12 months while pain and dysfunction scores reduced in their patients. That's from his article. Next slide. So just to summarize, regenerative medicine seems to be another forefront for us in clinical practice in oral surgery. Our experience with the Enduret PRGF protocol has shown how the power of growth factors can improve healing and regeneration. Our experience has been positive, and I dare say that the outcomes that we're getting with PRGF for both bone regeneration and managing TMDs may exceed results that are achievable, say, with autogenous bone for bone grafting. Next slide. So this is our bibliography that's available. The top part is as it relates to managing patients with TMDs. The bottom half is a bibliography as it relates to using PRGFs with bone grafting. And those are our email addresses there. If you're interested in having these bibliographies, please don't hesitate to reach out to us. We'd be glad to send you this list. Next slide, Pete. So that brings us to the conclusion of our lecture. And sorry, we had a little bandwidth issues there that delayed some of the slide changes. But thank you for your patience. Thank you for the privilege and opportunity to speak to you all tonight. And thanks, Pete, for your great work on this. Great working with you.
Thank you, everyone, as well, and thanks, Dave, for sharing those clinical cases.
Thank you to Robert and Tony and CAOMS. Thanks, Ellen, for organizing this. And I'm looking forward to seeing you all in Vancouver. Thank you very much.
Great. So, good evening, everybody. Dr. Sutka, Dr. Ta, thank you for an excellent presentation. It goes without saying that it takes a tremendous amount of effort to document cases the way you document them. And Dr. Ta, I don't know you as well. Dave, I've known you for a long time, and I'm truly never cease to be amazed at the amount of clinical documentation and teaching that you provide to our community. So thank you so much for all the teaching that you do. There are, and obviously I would like to thank our COMS members. We have a really good turnout tonight. At one point, I think we had just shy of 100 people online, which is fantastic. And it's just a testament to this modality of us being able to communicate and get together. So there are a couple of questions. What I'd suggest for the sake of time is maybe you can do a kind of rapid fire question sequence so that we can cover some of the questions. Number one, I'll just say infection rate with titanium mesh is notoriously something that people that do this type of regenerative work often comment about. Can you comment on that incidence in your hands? And there are some people that I speak to that basically say they get 100% titanium mesh infection when they do these cases. I'm just curious. Clearly, that has not been your experience, and I'm wondering if you have any tips or tricks for how you've modified your protocols to maybe avoid that, please.
Yeah, I haven't seen infection, and I think part of the reason for that is one of the effects of platelet-rich growth factors. It's bacteriostatic. So even when we've had some dehiscences, either from trauma, from a partial denture, or just the flap, the biotype of the mucosa couldn't handle the degree of advancement that was necessary. Even when we've had dehiscences, I just put my patients on dilute hydrogen peroxide mouth rinses and tell them to keep it clean, and they're able to keep it clean. And if it's a small dehiscence, I wait until implant surgery to take out the mesh. If it's a bigger dehiscence, I'll take the mesh out. as a separate procedure, let it mucosalize, and then put in the implants. But I haven't seen infection per se.
Okay.
Pete,
How
have
long
you?
did it wait?
I would share Dave's experience there, and up until we started using the PRGF material, I actually had shied away personally from a GBR type procedure because I was having the same problems, tenting screws with GBR type grafting with resorbable membranes. It just block grafting always seemed to work better. BMP was successful, but was prohibitive for cost. But I do think there is something to attribute to the bacteriostatic nature of the PRGF that has really, I can't remember the last time I did a block graft for the reason that this technique seems to work. And we do have dehiscences, but I don't think that dehiscences are infections in the bone when we uncover in a staged fashion seem to really work. So maybe it's the material, but certainly it's changed my philosophy from shying away from GBR type procedures, and I think the growth factors, probably through the angiogenesis, do help the healing process.
Sure I'm probably not the first person to bring up the notion of a resorbable membrane. Given the growth factor potential and all the potentiation of healing that the products that you're using provide, wouldn't it be interesting to have a resorbable membrane or a resorbable scaffold that would substitute for the titanium mesh that would preclude an exposure surgery to remove that mesh? What do you think about that?
Sorry, Tony, I didn't catch your whole question there.
My question is, have you encountered, or do you foresee on the horizon the possibility of using a resorbable a resorbable mesh that offers the similar initial rigidity to the titanium as a space maintainer that would then preclude the necessity for a surgery to remove it? And given the potentiation of healing that the F1 and F2 material provides you, would this be an opportunity?
I think in my hands, and it's not that we've been using this for a super long period of time. It's been a few years, but I think what we like most about the titanium mesh is just its volume stability and our ability to pre-bend it ahead of time and know that it's more so just going to be alleviating any pressure resorption of the graft material underneath. And there is described techniques by Anichwa who doesn't even use a titanium mesh and uses just the sticky bone itself. So could we theoretically just use the sticky bone and put the F1 membrane on top? I think it's possible to consider using. And I think it just depends on the type of defect we have, whether it's more of a concavity and the shape and nature of defect, whether we're trying to build vertical height or just horizontal. So perhaps case specific in terms of what we use would be good. I think the mesh, we can bend it to the predictable 7 millimeters, as Dave says, and we know it's going to hold at 7 millimeters. And we do find the graft consolidates right up to the margin of where that mesh is. So it seems to be working, and I wouldn't say it's not possible to do it without a resorbable membrane, but it seems to be working.
How long do you wait from the graft procedure to implant placement? What's the healing interval from?
I'm waiting six to 8 months.
Okay.
And if there's a dehiscence, I'll remove the mesh and give it about 6 to 8 weeks of maturation for the epithelium or the mucosa.
Okay. The bone grafting material that you place underneath the mesh, is it FDBA, or do you use a combination of xenograft and freeze-dried bone, or what are you placing underneath the mesh?
For all my
I
science,
can answer that. We're using human allogeneic bone mineralized particulate bone grafting material.
Okay. And I think I caught that you're soaking it in the F2 element.
And that's mixed with the and we sometimes mix BioOS in with it, and Pete uses BioOS by itself in the sinus grafts.
I for my sinus list, they're always BioOS is what I use. For all of my on-leg grafting, I'm using the allogeneic bone, And what we'll do is the F2 comes as a liquid, and that F2 is a liquid, and it can be activated as a liquid, or you can bake it for 8 to 12 minutes with bone to make it that sticky bone. So
Okay.
for all the onlay grafting, we'll bake it to make that sticky bone and put that underneath the crib.
Okay. Forgive me for asking if unless I missed it, but can you just in a nutshell summarize the molecular difference between F1 and F2?
Yeah, F1 we think of as more soft tissue healing. It's F1 is we consider as fibrin. It has a concentration of about 1 to 1.5 times physiological levels of platelets, and the F2 is kind of the concentrated growth factors in the plasma, and that's at a 2 to 2.5 time. So studies kind of show that there's no real benefit going higher than 2.4 times concentrated of the platelets.
Okay, great. So if you had somebody like me, for example, who's going to ask you, you know, I want to get this product, I'd like to integrate it into my practice. I do a lot of implant surgery. What are the types of cases that you would recommend? I think I'm just going to intuitively shy away from that full arch titanium mesh case that you guys I mean, that's incredibly artistic, and I see there's a tremendous amount of know-how that goes into doing that. That's not an easy case to replicate at your first go. So kudos to you guys for achieving that. It's incredible. What would be your advice to using it? Is there any value to putting this kind of material, such as F2, in wisdom tooth extraction sites? Have you tried that, and have you seen any big differences? Or might you suggest other cases that we could introduce this into our practices progressively?
I have used it in older patients where I anticipated a lot of bone removal, for difficult, but obviously symptomatic teeth that had to come out, and also in cases that were obviously a dentigerous cyst where there was a large defect. I don't use it routinely. I mean, young healthy patients heal without us doing that, but I have used it for select cases where I was worried about healing.
I've done much the same. I don't routinely use it because there is a time frame that it takes as well. So unless you plan around it, you don't have the time to draw the blood, spin it down. That's about a 30-minute procedure. I've used them in cyst regions, in particular, perhaps a cyst that would benefit from potentially being reconstructed, but not knowing the histology. I've never been one to really put a lot of particulate bone in there because I don't want to mask a recurrence. But the F2 being radiolucent on insertion still allows me to kind of track any ossification I find. I've used it in a nerve repair case instead of using Axogen because it does have neural growth factors in there, and my case series is an N of 1. So we did have the lectures, but due to time constraints, I used the F2 to reapproximate the two ends of the severed nerve and placed an F1 surrounding that with return of over 80% sensation after a complete nerve transection from a deeply impacted tooth that was anticipated to be having a neurosensory deficit afterwards. So not enough to have any literature behind it, but certainly a case that was a great case report to do.
Great. Well, gentlemen, I think we've come to the end of our session. Once again, Dave and Peter, thank you so much for sharing your wealth of knowledge in this field. It's truly appreciated. Thank you to the members of our association for participating. I would be very remiss in not thanking the Cinca company and the group at BTI for supporting this event. It's your support is invaluable and very appreciated. And certainly want to remind everybody that we're looking forward to seeing as many of you as possible in Vancouver at our upcoming International Association meeting in June. And with that, I wish you all a very good night. Thank you so much for participating.
Thank you,
guys.
Thank you, Tony.
Thanks very much. Good night, everybody.
Have a good night.